let's have a look at some other differential diagnostic options. Let's imagine the patient is describing low cervical pain. Is it a cervical problem? Or is it a thoracic problem? Well, how can you find out? Well, the neck flexion is not going to help you too much because this is a dural test, so could be cervical problem, could be thoracic problem. But if you find that other neck movements in your functional examination, other articular tests are positive, then you have a cervical link. It's all about the question, how can I provoke the patient's symptoms? If some scapular movements in the examination are positive, or taking a deep breath creates or stimulates the symptoms, then we have a thoracic link. And then, of course, I refer to the thoracic examination in another lecture. All discs are alike, but all other disorders are different. And I used exactly the same quote when we talked about red flags in the lumbar spine. Well, let's have a look at our functional examination again. We did some active tests, passive tests, and resisted tests, and the neck movements, extension, flexion, side flexion, rotations. Let's imagine we find a muscular pattern. And what does that mean? Well, that means that the resisted tests are more painful than the active and the passive tests. You can forget an internal derangement. This is not the image of an internal derangement. So we can think of a real muscle problem, fracture, metastasis, glandular fever. Psychogenic patients also love resisted tests. They mostly react very positive on all resisted tests, and this is of course also suspicious. There is a special partial articular pattern we also described in the lumbar spine. Side flexion away from the pain is the only movement which is painful and limited. You also don't expect that with an internal derangement that points in the direction of some extra articular lesion. But again, I would like to emphasize that just one finding doesn't say all. It's the collection of the puzzle pieces. If it's not an internal derangement, you're going to hear other elements in the story. You're going to find other patterns in the clinical examination. What about a full articular pattern? Well, of course, if the patient is an elderly patient, okay, arthrosis, no problem. Full articular pattern with a hard end feel. Remember, what is the full articular pattern? No limitation of flexion, equal degree of limitation, side flexions and rotations, and also some limitation of extension. This is the full articular pattern. If you see that in young patients, this is of course abnormal. Your first idea is going to be a pretty active ankylosing spondylitis. But in a case of metastasis or after injury, if there's a fracture, we can also see that. One of the next tests we did was shrugging the shoulders. There could be a limitation, a unilateral limitation, which is very, very rare. But that could be connected with a contracture of the costa coracoid fascia or metastasis in the scapula, but very rare. Much more frequent is that during this movement the patient has pain. And if the patient has pain somewhere between the scapulae, mostly, that goes together with a thoracic internal derangement. But if the patient has pain under the clavicle anterior, that can go together with a subclavius muscular lesion, which is very rare. Or also anterior pain can go together with a sternoclavicular arthritis. But then, of course, other movements like retraction, protraction, and so on will be positive, of course. We did an arm elevation, and there are numerous reasons for pain on the arm elevation or limitation. For instance, we talked about mononeuritis, about fracture, about painful arc, and more specifically mononeuritis. I refer to the lectures on weakness on resisted test in the shoulder. We talk about suprascapular nerve, the long thoracic nerve, the spinal accessory nerve. We have the typical story of the mononeuritis, but I refer to the other lectures. Fracture, spinous process fracture, rib fracture could also influence the range of motion of elevation. Painful arc, well, in the specific shoulder chapters I gave you 6 reasons for a painful arc, and we discussed that in detail. Imagine you find motor deficits on your root tests, and imagine you find bilateral deficit, too much deficit, and multiradicular deficit. This is suspicious, okay? Safety first, go for medical imaging and try to find out if nothing else is going on. A T1 nerve root pressure resulting in T1 weakness, remember your functional examination, adduction of the little finger. Very rarely this is a disc protrusion. Check it, okay? Because we don't want to make any mistakes, okay? It is possible. I've seen it. I've seen it once that it was really a lateral protrusion with pressure against T1. It's possible, but it's certainly not as frequent. It certainly is not frequent. Another strange story is the neuralgic amyotrophy. This is also very rare. Has a spontaneous evolution in about 1 year. It starts suddenly. The patient suddenly has cervical pain. A lot of pain. But when you do your test, there's no limitation of the passive test. So if you think of an internal derangement and the patient says, I have a lot of pain, you must find pain and limitation on passive test. He has bilateral arm pain, which evaluates towards unilateral arm pain. During 2 months, it's quite intensive, then it gets better. Muscle weakness for different roots, so that sounds really suspicious. But okay, it's another pathology. And where is it coming from? Well, could be related with a viral infection, could be related with an allergic reaction. Of course, those are the details you have to think of when we are sure that the more obvious lesions are not present. Let's imagine there is a nerve root compression by an osteophyte. Of course, this is a very gradual evolution, so the patient doesn't have too much pain. He has slight pain, but slowly but surely it gets worse. And mostly it's the C5 nerve root which is compressed by osteophytes. And clinically, in your testing, you find what I call a fixed pattern. For instance, the patient is doing an extension movement and for instance, combining with a rotation, and then you clearly get a peripheralization. You get out of this position, the pain goes away or is better. You go again to that position, it's worse. And you repeat that for 20 times, and 20 times it's going to be more painful, and then the symptoms are improving, more painful. But after 20 times, it's not better, it's not worse. No change. Actually, it's the same clinical image of a dysfunction syndrome, as we described in the lumbar spine, but here the pathology is quite different. Of course, medical imaging is going to give you some extra information. But this is quite interesting, I think. Is the nerve root compressed by an osteophyte or by a disc? Well, if it's a lateral protrusion, well, we already know that probably the patient is older than 35 years old. Osteophyte, the patient is older. The disc patient probably described a shifting pain. Yeah, first neck-shoulder pain and then arm pain. The osteophyte doesn't have neck-shoulder pain, he just has arm pain. Disc, spontaneous evolution. Osteophyte, of course, no evolution. Disc, oh, could be quite painful. Osteophyte, slight pain. With a disc, the pain is the main element, and if the pressure on the nerve root gets worse or bigger, okay, then we can talk about weakness. But with an osteophyte, weakness is going to be the main symptom. More weakness than pain. Disc, you find a partial articular pattern. Osteophyte, you find a fixed pattern, as I just explained. With disc, perhaps some weakness. With osteophyte, serious weakness. Disc, mostly C7 root. Osteophyte, mostly C5 root. So if you keep that in mind, that's going to be diagnostically pretty helpful. Another pathology is a high cervical arthritis. We talk about young patients who have some high cervical pain during some weeks and increasing limitation of movement, but there is a discrepancy between the limitation of movement in the rotations and the other movements. Rotations are very limited, but if you think of an internal derangement causing a lot of limitation of rotation, then at least extension or flexion should also be impaired. And here we don't see that. So you find a strange discrepancy. Yeah. The end feel is quite soft. So actually this is an aspecific inflammation. Yeah. So it's also not frequent, but keep that in mind. If the patient has metastases, then the clinical image can also be variable. If we talk about the high cervical level, then possibly we don't find any positive neurological signs in our examination, because remember, our main root tests start as from C5, C6, C7 and so on. So if there is a problem in the lower cervical levels, then perhaps you can find weak root test C6, C7. Yeah, you find the elements, the inherent unlikelihoods. But to summarize, when do you think of a neurofibroma? Well, you don't have articular signs, so the articular movements, that looks pretty good. The patient is too young to have root pain by a disc. The arm pain gets even worse after 6 months, so you can't correlate that with an internal derangement. Coughing is painful in the arm. The symptoms started distally. You have an expanding pain, too much deficit, bilateral deficit, more than one root, perhaps spinal cord symptoms. So when you find a combination of those things, please go for further examination. This is suspicious.